Endoscopic management of gastroesophageal reflux disease following sleeve gastrectomy using the anti-reflux mucosectomy procedure. Doctors Hathorn and Jarapino do not have any financial disclosures. Dr. Thompson is a consultant for Olympus, Boston Scientific, and Apollo Endosurgery. Sleeve gastrectomy is the most common bariatric surgery being performed in the United States. Studies have reported an increased rate of de novo gastroesophageal reflux disease after surgery and high rates of new onset of Barrett's esophagus. While no endoscopic procedure has been widely accepted as standard treatment of GERD, the anti-reflux mucosectomy procedure has come into the forefront in recent years as a safe and effective endoscopic procedure for reducing GERD symptoms. The presumed mechanism is due to scar formation after healing of the mucosal defect. To our knowledge, all prior cases have been performed in patients with normal gastric anatomy. Our case involves a 71-year-old female who presented to our clinic with a 5-year history of progressively worsening GERD following sleeve gastrectomy. She had a history of GERD prior to her surgery, but the symptoms were not as severe. She experienced daily symptoms despite maximal lifestyle modifications and BID PPI. Her GERD-Q score was 11, indicative of 89% likelihood of GERD. She underwent a 24-hour pH and impedance study, which showed an increase in acid reflux in the upright position with a Demeester score of 17.7. While there was a normal number of non-acid reflux events, these events did correlate with the symptom of regurgitation. Given she was not a candidate for surgical conversion to a Roux-en-Y gastric bypass due to other medical comorbidities, the decision was made to pursue an endoscopic anti-reflux mucosectomy, or ARMS procedure. Prior to the start of the ARMS procedure, pulsed APC was used to mark an 85% circumferential mucosal area of the gastric cardia to be treated, thus sparing 15% of the circumference around the cardia along the greater curvature of the gastric sleeve. Submucosal lifting was performed using normal saline solution mixed with methylene blue and epinephrine. EMR was performed using either a band or a cap EMR kit. A total of 10 resections were performed in a partial circumferential fashion. Diagnostic EGD was performed first, notable only for mild irregularity of the Z-line and mild erythema in the stomach, seen here in the retroflex view. Prior to the start of the mucosal resections, pulsed APC at a flow rate of 0.8 liters per minute and 45 watts was used to mark the mucosa. The area between the two marks of APC is approximately 15% of the circumference around the cardia, which is the area that we were not planning to treat during the case. This step is critical to prevent stricture formation, which may be seen with full circumferential resection. Preparations were then made for the initial endoscopic resection. The marks from APC were again identified to ensure the initial EMR would be performed just outside this region. The first step involves injection of the normal saline, methylene blue, and epinephrine solution in order to lift the mucosa from the muscularis propria. Next, endoscopic mucosal resection is performed. In the initial EMR, we use the band EMR device, as seen here. Finally, a snare is positioned below the level of the band and is used to resect the mucosa. The same steps are repeated for the second resection. The area immediately adjacent to the prior resection site is targeted. In this case, the second EMR was also performed with the band EMR device and ultimately was removed with the snare. We were concerned that we included a portion of the prior resection site as seen on the left portion of the banded tissue, and we thus opted to perform the resection over the band. Here, we see the retroflex and forward-facing view after our initial 2 resections. Now, for the third and all subsequent resections, the band EMR kit was replaced with a cap EMR kit. The tissue is still injected in order to lift the mucosa from the muscularis propria. However, in this scenario, the snare is fitted around the mucosa while it is suctioned into the cap device. Once the snare is firmly in place, the suction is released and the mucosa is able to be resected. The same procedure is performed for the fourth resection, and shown here is the result in forward view after our first 4 resections. There are several reasons why we switched from the band to the cap EMR kit. The band EMR kit allowed for a smaller amount of mucosa to be resected, and thus was more time-consuming, leading to a longer procedure time, and it proved difficult to maneuver the injection needle and the snare through the banding cap. When performed without the band EMR kit, we were able to resect larger pieces at a time, thus reducing procedure time, and it was much easier to maneuver the snare into position for the resection. This and prior arms procedures have been performed with a resection rather than a band and slough technique. Theoretically, the use of the band and slough technique may have a lower bleeding risk. However, it may not provide the same clinical results due to unclear impact of mucosal bridges between the bands. The 9th resection was performed in similar fashion. The tissue was then re-examined in the retroflex view, and finally, the location of the last resection is found. Notably, in this scenario, given the difficulty of maneuvering the scope into position, the snare has already been opened and fitted around the cap. Thus, once the mucosa is suctioned into the cap, the snare is already in position to be closed around the mucosa, as seen here. As the last step, prophylactic hemostasis of the vessels in the muscularis propria layer was performed using a coagulation grasper. Shown here is the final outcome in the retroflex view. As noted here, we have avoided the 15% of the circumferential area that was initially marked in the beginning of the case. Her GERD symptoms were significantly improved following the procedure. Her GERD Q score at 3 months was 8 and showed specific improvement in sensation of heartburn, regurgitation, and need for over-the-counter medications. Repeat 24-hour pH and impedance testing at 7 months showed no increase in acid reflux or non-acid reflux, a normal Demeester score of 5.8, and no correlation with rare regurgitation and reflux. In conclusion, ARMS can provide a safe and effective means for symptomatic acid reflux control for patients with a prior sleeve gastrectomy and medically refractory GERD whom are not candidates for conversion to Roux-en-Y gastric bypass.